Hello everybody, welcome to Raha Media, the media that informs you about your health, psychology, technology, anthropogeography and overall concepts of religion. Today we will see esophageal cancer, lecture outline and detailed content. In this content we will see definition, sign and symptoms, differential diagnosis, causes and risk factors, epidemiology, diagnosis, treatment, prognosis, prevention and public health measures, and there is also an update on the treatment of esophagus cancer. Let's go.
Hello everybody, welcome. Today we will see esophagus cancer. When we start from the definition, esophagus is the muscular tube that carries food from mouth to stomach. Its length is 25 centimeters. Starts from lower border cricoid cartilage at the level of C6 vertebra and ends at cardiac opening of the stomach at the level of T11 vertebra. When we define cancer itself, what is cancer? You can take as an assignment what is the difference between carcinoma and cancer. This term is more look like similar, but there is great difference between them. So what's the difference? What is carcinoma? What is cancer? Take this as an assignment and answer under the comment. So when we see cancer, cancer happens when normal body cells lose control of their growth. Normally cells grow, divide and die in an orderly way, but when something damages their DNA means the cell's instruction book. The cell starts dividing abnormally when DNA is damaged and refuses to die, forming a tumor. When these cells grow in the esophagus, it is called esophageal cancer. Esophageal cancer has two main histologic types: esophageal squamous cell carcinoma, which arises from squamous epithelium, and it is common in esophageal cancer belts, and esophageal adenocarcinoma, which arises from glandular metaplasia, which is caused by Barrett's esophagus, more common in Western countries. And knowing its histology is important for clinical significance, as to know its risk factors, distribution and treatments, because the risk factor is different depending on histologic. A key point or gold standard is diagnosis requires endoscopic visualization with biopsy and histopathology. What is the signs and the symptoms? What patient is present with? Progressive dysphagia or initially solidus. The patient present with dysphagia, initially solidus, then liquidus. Difficulty of swallowing. So that is when a patient with the case of esophagus cancer comes with difficulty of swallowing on the first time. In the beginning, they can't swallow solid things, solid food. After that, they face difficulty of drinking even liquids. Most common presenting symptom. The other one is odynophagia, painful swallowing. Even if they swallow food, it is very painful. And unintended weight loss and reduced oral intake. This is obviously when they can't intake food, when they can't eat. This causes unintended weight loss. And the other one is regurgitation or sensation of food sticking in chest or throat, chest pain or retrosternal discomfort, persistent cough, hoarseness, recurrent laryngeal nerve involvement. And these are the symptoms. And the other one is upper GI bleeding, less common but may present as melena or iron deficiency anemia. It could caused by iron deficiency anemia, but also sometimes it is the sign and the symptom of esophagus cancer. And the other one is constitutional symptoms. If metastatic, the patient come with fatigue. They are very weak and fatigue and anorexia. They have no appetite for food at all. In this case, in this sign and symptoms, you should note that early disease may be silent. Many patients present late with locally advanced or metastatic disease. So sometimes the patient didn't understand this sign and symptoms early. They understand the sign and symptoms after the disease was advanced. What differential diagnosis or condition is that mimic esophageal cancer? There are conditions that mimic esophageal cancer. For example, benign strictures or peptic strictures from GERD, and eosinophilic or infectious esophagitis or candida, herpes, achalasia, or motility disorders, food retention or dysphagia, and Zenker's diverticulum or pharyngeal dysphagia. And benign esophageal rings or webs, or what we call Schatzki ring, and foreign body impaction. Hypopharyngeal or laryngeal cancer compressing the esophagus, gastric outlet obstruction with vomiting or regurgitation, or less common mimic. And to differentiate it, you should work up, must rule out this before confirming malignancy. So you should use endoscopy plus biopsy are required. Endoscopy plus biopsy required to differentiate whether it is esophagus cancer or another disease. What causes cancer? How cancer develops, mechanism and exposure. Basic mechanism is repeated injury to the lining tissue of the esophagus, which leads to DNA damage. Then mutation on oncogenes or tumor suppressor genes. Then it leads to abnormal cell proliferation and failure of apoptosis. Then malignant transformation. Chronic inflammation and impaired DNA repair accelerates this process. Major risk factors with mechanistic notice: tobacco smoking. Tobacco smoking as carcinogens cause DNA adducts and mutations. A strong association with esophageal squamous cell carcinoma. So smoking tobacco or cigarette is a risk for squamous cell esophageal carcinoma. Heavy alcohol consumption, synergistic with tobacco for esophageal squamous cell carcinoma, produces local mucosal injury and metabolic carcinogens. And chronic gastroesophageal reflux disease, which leads to Barrett's esophagus, intestinal metaplasia, which increased risk of adenocarcinoma. So chronic gastroesophageal reflux causes adenocarcinoma. Dietary factors: low intake of fresh fruits or vegetables, which means antioxidant deficiency. Diet is high in salted, smoked, fermented foods or nitrosamines implicated in high-risk regions. The other risk factor is thermal injury or very hot beverages foods. Repeated thermal injury to the mucosa increases risk or observed in high incidence old regions where very hot tea or fluid is commonly consumed. The other one is obesity. It increases intra-abdominal pressure and gastroesophageal reflux disease risk, which leads to higher adenocarcinoma risk. And the other one is the disease called achalasia, stasis and chronic irritation, which increased esophageal squamous cell carcinoma risk. And the other risk factor is human papillomavirus. Association suggests in some studies for esophageal squamous cell carcinoma, but evidence variable by region. And the last one is family history or genetic predisposition. Rare inherited DNA repair defects or familial clustering. So this is all about risk factors and the causes of esophageal cancer. Let's see epidemiology or global pattern burden. Global burden or recent estimate is 511,000 new cases and 445,000 diseases globally in 2022. Esophagus cancer remains a high mortality disease. Age standardized incidence and mortality are higher in East Asia, parts of South Asia, and certain highland or cold regions of Africa, especially Oromia, RC and the Valley zone. Known for especially it is esophageal squamous cell carcinoma. Histology by region, esophageal squamous cell carcinoma predominates in the esophageal belt, northern Iran, Central Asia, parts of China, some East African highlands, and esophageal adenocarcinoma incidence increased in many Western countries linked to gastroesophageal reflux disease and obesity. How to diagnose a person with esophageal cancer? Investigation and staging workflow. First line investigation, upper GI endoscopy. Esophagogastroduodenoscopy or EGD with targeted biopsy, definitive diagnosis. So first we should use EGD or esophagogastroduodenoscopy because it is definitive diagnosis for esophageal cancer. The second one is barium swallow, useful if stricture prevents scope passage, shows filling defect or stricture pattern. Endoscopic ultrasonography, EUS, best for local T and N staging, depth of invasion and nerve nodes when planning curative therapy. The fourth one is cross-sectional imaging, CT chest abdomen plus or minus pelvis, assess regional spread and distant metastasis. The fifth one is PET CT, useful for detecting distant metastasis and nodal disease that change management. The sixth one is laboratory test, CBC for anemia, LFTS to know metastasis, nutrition assessment. The seventh one is molecular or biomarker test, PDL1 expression, CPS may guide immunotherapy decisions in advanced disease. Staging of cancer, it depends on TNM staging based on tumor depth. T stands for tumor and regional lymph nodes, N for regional lymph nodes, and M metastasis, distant metastasis. So staging determines curative versus palliative intent and guides therapy. How to treat esophageal cancer? It depends on its stage and the goals. Treatment depends on its stage and its goal. Multidisciplinary approach, surgery, medical oncology, radiation oncology, endoscopy, nutrition, and palliative care. Endoscopic treatment for very early mucosal confined tumors, endoscopic mucosal resection or EMR or endoscopic submucosal dissection for small superficial lesions, often EAC or high-grade dysplasia, surgical resection or esophagectomy. Main curative operation for resectable disease, various approaches, transhiatal or transthoracic, requires skilled teams and perioperative care. It is somewhat complex and it requires skilled teams and perioperative care. Neoadjuvant chemotherapy or CRT followed by surgery, standards for many locally advanced tumors to downstage disease and improve outcomes. Example, cross regimen and adjuvant therapy, immunotherapy. You can find from the references below. You can see the updates. There is some updation on treatment. Definitive chemoradiation alternative to surgery for selected patients with localized unresectable disease. Palliative interventions, esophageal stent for obstruction, palliative radiotherapy, pain control, nutritional support or PAG feeding, jejunostomy, and systemic therapy for symptom control is important. Multimodal care and nutrition optimization are essential given high rates of malnutrition in esophageal cancer patients. What about this prognosis? Esophageal cancer has poor overall prognosis because many cases are diagnosed late. This is a big issue. Many cases are diagnosed late. That is why its prognosis very poor. Survival varies greatly by stage. Early localized disease may be curable. Metastatic disease median survival measured in months, but improving with newer systemic therapies. How to prevent and what is its public health measures? Primary prevention: tobacco cessation and avoid heavy alcohol use. Largest modifiable risk for especially esophageal squamous cell carcinoma. Also, it reducing consumption of very hot beverages. Let's drink cool before swallowing. Improve diet. Increase fruit and vegetable intake because they use as antioxidants. Reduce salted or fermented foods. Control obesity and treat gastroesophageal reflux disease early to reduce progression to Barrett's and adenocarcinoma. Safe food preservation and reduce exposure to anthocyanins in high-risk areas. Vaccination and infection control when relevant. Example, manage HPV where implicated. And secondary prevention or early detection, surveillance endoscopy for high-risk patients with Barrett's esophagus, or regular surveillance endoscopy with biopsies per guidelines to detect dysplasia or early adenocarcinoma. Public awareness about progressive dysphagia and early health-seeking behavior in high-incidence regions. So this is all about esophageal cancer, and there is also references and further reading authoritative sources. You can find the reference if you need to read further. You can use these references. Thank you.